we welcome Dr. Roy Smith. This is the first time he'll be doing one of these videos, and we are so grateful for him. Dr. Smith is a professor at the University of Pittsburgh, and he's also a porphyria expert. And we are so glad because Dr. Smith has joined our scientific advisory board, and I can tell you he has been a real blessing to the Porphyria Foundation in terms of his brilliance in porphyria, but also his sensitivity to patients. And I would like to, he won't want me to say this, but he wouldn't even take an honorarium to do this today.
Wow.
So we appreciate Dr. Smith, and Dr. Smith, we'd like you to come on now and begin your presentation. I will also note that after the presentation, we will review questions that have been sent in ahead of time, as well as take questions from the audience today. And then we've got another wonderful part of this program. Mayra Martinez will be giving her presentation as a patient, and so will Sharon Dill, who is with us now. And we will also have a video of Megan Parrish that I think all of you will enjoy. So stay tuned for the entire Porphyria presentation today by the American Porphyria Foundation, where patients are first. Dr. Smith.
All right, so I'm going to try to share my screen. This will be an achievement if I can do it. So here we go. And
there we go.
So let me put on presentation mode here so it fills the screen up. So anyway, I was asked to give a very brief presentation about porphyria. So this will be very brief, to say the least, and it's going to be very basic because I don't want to be too wonky about it. So what I hope to do is sort of define the disease, go over the types of porphyria, especially acute hepatic porphyrias, which is the subject of today, explain why it happens, and perhaps some discussion about how the diagnosis is made and questions that might need to be asked to your physicians when this is considered, and what you can do about it. And then also a proposal to the porphyria community at large about how to further improve the medical approach to patients who have porphyria, which in the United States, at least, is extremely fragmented. So porphyria is an inherited disorder. There are 8 different types. The type we're discussing today is acute hepatic porphyria. All of them are characterized by the accumulation of porphyrins and porphyrin precursors, which I'll explain in a minute, in the urine, in the plasma, and also to some extent in tissue, which results in the pathology of the disease itself, the abnormalities that you may be experiencing. They result in malfunction of specific enzymes needed for heme synthesis. And in general, it's hereditary. There are acquired forms of porphyria, although the nomenclature for them is disputed in the medical literature. Types of porphyrias that you see are listed here. The cutaneous porphyrias we're not going to discuss today, so we're going to maintain a discussion with the acute porphyrias, which are acute intermittent porphyria, which is by and far the most common in the United States and in Europe. Variegate porphyria, which is quite common in Europe and the United States, and it's the founding mutation appeared to be among the Dutch. Hereditary coproporphyria, which is quite rare, and aminolevulinic acid dehydratase porphyria, or ADP, of which there's only been 9 confirmed cases in the United States, well, in the world actually. So I'm not going to really spend a lot of time talking about ALA porphyria at this point. This diagram, shows some of the chemical changes that occur in patients that have porphyria. Don't worry about the names and the scientific names and things like that. It's not important. This is just the easiest one I could find on the internet. But basically, what happens is there's a progressive alteration in the structure of heme and porphyrinogen precursors, which lead to the symptoms and signs associated with acute hepatic porphyria. And these changes include the formation of a ring chemical, which can be light reactive. And it's dependent upon the activity of at least 2 enzymes, which are either hyperactive or deficient in their activity. ALAS, aminolevulinic synthase, is an enzyme which is responsible for forming aminolevulinic acid. And when that is increased for any reason, as an example, exposure to barbiturates or birth control pills sometimes, or just simply dieting, or perhaps even anemia, ALAS is increased in tissue, primarily hepatic tissue, but also in red blood cells. And what that means is you have an overwhelming production of the other downstream precursors for heme synthesis. That includes porphobilinogen, and further downstream abnormalities. As these constituents build in concentration, they may pass through developments dependent on other enzymes that may be deficient. And it's these deficiencies of these secondary enzymes in the downstream pathway from ALAS, which leads to the formation of the disorder of acute hepatic porphyria. ALAD, aminolevulinic deaminase, is an enzyme that is deficient and is responsible for ADP. Patients who have acute intermittent porphyria have a deficiency in the PBGD enzyme, which is porphobilinogen deaminase. And because of that, the upstream abnormalities, the upstream constituents increase. And those upstream constituents can be toxic. Aminolevulinic acid is, without any question, neurotoxic and may be the primary cause of the signs and symptoms associated with acute intermittent porphyria. There is an issue as to whether porphobilinogen itself is neurotoxic. I think that's still debatable. And in animals, it certainly appears to be so. In humans, it's still a little bit debatable. In patients that have a defect in the so-called CPOX enzyme, when that enzyme becomes overwhelmed, then you get a buildup of coproporphyrinogen, and that causes the disease called hereditary coproporphyria. And then if you have a defect in PPOX, you get a disease called variegate porphyria. So when you think about acute hepatic porphyria, you have to understand that it's basically a two-hit phenomenon. That is, you can have a defect in a downstream enzyme and be completely asymptomatic for most of your life. But if you have that same defect and for some reason aminolevulinic acid synthase has been stimulated to become more active, then you will develop symptoms. Now, I had mentioned acquired porphyria earlier on, and although that's not a hereditary defect, you can see that in people who have some reason to have ALAS increase to the level that it overwhelms normal downstream enzymes. And being a hematologist, I see this in people that have uncontrolled hemolysis or destruction of red blood cells in their vascular system. Now, as these constituents of the pathway develop, they develop different characteristics. Those that are ringed, as indicated by the the blue cartoon there, part of the cartoon, these take on a characteristic which allow them to be stimulated by exposure to certain wavelengths of light. This allows these disorders to be diagnosed, and it also serves as a source of discomfort and damage to the patient that has these type of disorders. Why is that? It's because these constituents circulate in the plasma and serum. They distribute wherever blood goes in your body, and they are capable of causing oxidative stress to different tissues and tissue damage. Therefore, patients with acute hepatic porphyria may be predisposed to developing secondary disorders like gallbladder cancer or liver cancer. And for some of the disorders, they can develop blistering of their skin upon sun exposure. The photoreactive species that we see in the setting of acute hepatic porphyria have a specific plasma peak when it's exposed to a certain wavelength of light, as do the other porphyrias, which allow us to make a diagnosis, as indicated in this slide here. For those people that have acute hepatic porphyria, that range of plasma peak fluorescence is between 618 and 628 nanometers, as opposed to other types of porphyria that we won't discuss today, in which the peaks are slightly different. This chart, don't worry about the words, this chart sort of gives you an idea of what happens as these different porphyrin precursors are formed and they are metabolized. They are decarboxylated. That is to say, carboxyl groups are removed from the molecules themselves. And as that happens, the constituents become oxidized. And as that oxidation process takes place, the solubility of the molecule changes. It changes from being very soluble when you have a lot of carboxyl groups to being less soluble when you have 4 carboxyl groups and very insoluble when you have less than that. For that reason, we get accumulation of these constituents in liquid and in solids. And that's why when your doctor is trying to decide whether you have porphyria or not, or acute relapse, he's going to be looking at your urine, he's going to be looking at your plasma, and he'll also be examining your stools. And the reason for that is because those porphyrins that are less soluble are excreted from the body via bile, and bile is dumped into the GI tract. So patients that have constituents that are markedly increased, that have less solubility, would be those patients that have variegate porphyria or those patients that have hereditary coproporphyria. In that setting, the porphyrins in the stool will be markedly elevated, and the diagnosis would be largely dependent upon finding those abnormalities in a stool sample. That's in contradistinction to patients who have acute intermittent porphyria, in which, although porphyrins may be elevated in the urine or in the plasma, the diagnosis is far more dependent upon the presence of elevated porphobilinogens in the urine, because porphobilinogen is soluble. So the defect that we see in acute hepatic porphyria is this induction of this ALAS enzyme, followed by a blockade due to a decrease in the activity of downstream enzymes. In order for this to occur, the enzymatic activity is generally thought to be less than 50%, but that's not 100%. That's not absolutely true, because you can overwhelm enzymes easily just by markedly increasing ALS production. And this results in accumulation of these porphyrin precursors and porphyrins, which have pathologic activity in the patient themselves. So for diagnostic sampling, we look at the urine for the presence of aminolevulinic acid or porphobilinogen and total porphyrins and their fractions. The fractions can give us a hint as to what type of acute hepatic porphyria a patient may have. We look at plasma total porphyrins and fluorescence scan, since simply scanning a plasma sample may give us a diagnosis immediately. As an example, variegate porphyria has a specific result from a fluorescence scan that allows you to make a diagnosis literally within seconds. Obviously, we would look at a fecal sample and examine total porphyrins. A person who has hereditary coproporphyria would have very, very high coproporphyrins in the feces as well as in the urine. A person has variegate porphyria would have increased copras in the urine and in the feces rather, as well as increased protoporphyrins in the feces. And those would be diagnostic. We can also look at serum porphobilinogen in people that can't produce a urine sample. I just had a patient just this week that I saw who has, I think has acute porphyria, and he is in renal failure, doesn't produce any urine at all. So we had to check a serum porphobilinogen sample on him. And then in people that have ALD porphyria, there is a phenomenon that occurs in which zinc protoporphyrin in erythrocytes are increased. I don't know why that happens. I don't think anybody knows for sure what the mechanism of it is, but it's highly indicative of the presence of ALAD porphyria under those circumstances. Now, the other thing is you can measure enzymatic activity. I can't seem to get this to move. Let's see. My slide stopped working. There we go. Let me go. No. Let me go back. So the most common enzymes that we can look at are the porphobilinogen deaminase, which we measure commonly in red blood cells. The reason for that is that it's an enzyme that occurs in the cytoplasm of the cells. And red blood cells have no mitochondria where half the enzymes occur in. So it's easy to get it from red blood cells. The problem with red blood cells is that about 5% of the time, it's not a reflection of what's happening in other tissues. So it's really not absolutely necessary to make the diagnosis. It's confirmatory. Other things that could be measured in a red cell sample would be ALAD enzymatic reactions, but ALAD is unstable and it's not totally reliable. And the disease is so rare that there's probably no real indication for it in most circumstances. The problem with these enzymatic assays is that the results vary from lab to lab, and they're not necessarily comparable, and they can be affected by transportation of a sample from your laboratory to a reference laboratory. So I don't really depend upon them very much. So the big question is, what about DNA testing? And DNA testing is a confirmatory test. There are many variants and polymorphisms that have been associated with acute hepatic porphyria, particularly AIP. And the library is expanding all the time. I get these on everybody, but it is to expand the library. It's not to make the diagnosis. It's to confirm what I've already decided. And one of the problems with AIP is that the penetrance of the disease is very, very small. It's been estimated to be around 1%, which basically means that the great majority of people that have a mutation that has been associated with AIP don't have the disease and never will. But they do have what we refer to loosely as latent porphyria. That is to say, it's possible that sometime in the future, if ALAS is increased enough or the person's under stress, that they might have an attack of porphyria. That's possible. Or the other setting would be, particularly in females, is they've already had an attack. And that was when they first started having their periods. And they thought it was, menstrual pain, but now it's gone. And they have no problems after that. So in many ways, looking at these DNA tests, at least using them as screening tests, is dangerous because you can label a person with a disorder that they really don't have. And then you run into issues with people owning the disorder, blaming virtually everything that happens to them on the disorder, and with misinterpretations of the importance of their physical findings. So the physical presentation of acute hepatic porphyria is about the same for everybody, as indicated in the slide here. Back pain, abdominal pain, and this is important. The presentation is primarily that of abdominal pain without rigidity, so there's no evidence of infection. The white blood count is not elevated. But what is, I think, is sadly misconstrued is the frequency of which people have pain that is not abdominal pain. That is, they get back pain, shoulder pain. Many of the patients that I've seen for years have been people that have been diagnosed with fibromyalgia or anxiety disorder, depression, et cetera, when in reality, they have porphyria. I have one patient that was diagnosed at age 75 with porphyria. And she had pain since her first menses. So people that have hereditary coproporphyria and variegate may also develop blistering skin lesions. And for that reason, they can be mistaken for a type of cutaneous porphyria, which has a more benign prognosis. And these cutaneous lesions that they develop don't necessarily occur at the same time that they have abdominal pain or back pain or some other evidence of crisis. So sometimes it can be confusing. So why is the diagnosis delayed? The average length of time it takes to make the diagnosis of acute hepatic porphyria is 15 years. Why? Well, it's a rare disease, so most docs don't think about it. It's because it has a polymorphic presentation with pain at other sites other than the classic abdominal pain. Often there's an atypical presentation, brain fog, difficulty thinking, anxiety, depression, that sort of thing. And the other reason is because in the United States, there's presently no reliable way to make the diagnosis rapidly. That there is a new test that's available that's being used in some institutions, but it is still a laboratory-based test where you have to take a sample, give it to the laboratory, and it takes about 3 to 4 hours to get the results back. And that's not ideal when patients are coming into the emergency room complaining of abdominal pain. So I doubt that that's going to make much of a change in the United States. But so what happens is people come into the emergency room, terrible pain, no one knows what it is. Perhaps urine samples or other samples are obtained. the patient goes away, then they're never seen again, or the samples get lost. The other thing is the laboratory evaluation is often mistaken. I just saw a patient last week with renal failure who their local doc sent off a bunch of urine samples, and absolutely none of it had anything to do with the diagnosis of porphyria. The samples can be mishandled, and this is extremely common where samples are obtained. They're not refrigerated in a timely fashion. They sit there in the sunlight for hours, and this can distort the results. Perhaps not as much as people might think, but it can. And the third thing is a misinterpretation of laboratory results. I know this for a fact because at my own institution, which is a major university, I end up getting a lot of these results sent to me from other physicians to try to tell them how to interpret them. They can be difficult to interpret, and they're laboratory dependent. And finally, there's this thing which I call multidisciplinary confiscation, and that is that this is a disease that is not owned by any single medical discipline. And medicine in the United States is fragmented. It's fragmented because of subspecialization. There's people like myself who know a lot about hematology, and I know absolutely nothing about cardiology, at least since I was in medical school. And that applies across the board. And then on top of that, we have a setting in the United States where many people who do primary care end up being triage physicians or PAs, in which they're simply to identify an abnormality and send the patient off to someone else to make the final diagnosis or to manage it. And this doesn't work when people are living in small towns away from major universities. So, see if I can get this changed. So, what do you do about it? Well, there's several ways to treat people who have porphyria. One is just trigger avoidance. And trigger avoidance would be things like if you have acute hepatic porphyria, for heaven's sakes, don't diet, because a decrease in caloric intake is a trigger that turns on ALS. Certain drugs will do it. I don't memorize the drugs because there's lists and lists and lists of them, multiple places on the internet, including from the American Porphyria Foundation. Many of these drugs have never been shown in a scientific study to trigger porphyria, but they are reported to do so by either physicians or by patients. And for that reason, I believe them and I try to avoid them because I want to avoid someone getting sick. So trigger avoidance is very, very important. For prevention, at this point in time, the only approved drug available in the United States is givosiran, also known as Givlari, which is a drug that's administered subcutaneously once a month. My own experience with it is it's highly effective. It's really not more effective than Hematin, is my experience, but it's easier to give, and it does seem to work. Issue with givosiran is that about 10 to 13% of people get liver abnormalities. There have been cases that people have developed severe liver disease with it, and they can also develop very high homocysteine levels, which can be have major complications like pancreatitis. Heman can be used for the acute treatment of an attack. It's highly effective. It's relatively easy to give with very few side effects. In terms of prophylaxis, it's not approved for that purpose. It's unproven in that setting, although practically all of us think it works. But there is emerging evidence that the chronic delivery of Hematin as a prophylactic agent may be associated with refractoriness to therapy and an increase in the interval of attacks once hemotin is stopped. So there's a possibility that long-term hemotin therapy on a continuous basis might actually make the disease in the long term worse. There's also liver transplantation, which has its limitations because it changes your life forever and is reserved for people that have refractory disease. And in women who have attacks that are associated with their menses, a choice is to suppress their menses in some way with oral contraceptives or with gonadotropin analogs such as Lupron or something along those lines to suppress ovulation. And that appears to be highly effective, particularly in younger women. Now, the question comes up every now and then, does porphyria get better over time? And the answer to that is that if you have a type of AHP that is dependent upon cycling and you're postmenopausal, then there's a good chance that porphyria can get better for you. But the disease is still there. And if you somehow stimulate ALAS, you very well may have another attack of it. So it's a disease that can be difficult to diagnose simply because people don't think about it very much. Also because there's not a lot of familiarity in the medical field about it. I think that's an issue with medical education. This is a relatively rare disease, and there's lots of things that have to be discussed when you're in medical school, and this tends not to be at the top of the list. So from my standpoint, I have a lot of experience with trying to establish ways of coordinating care among patients at distant sites. I also happen to be the chairman of the Pulmonary Embolus Response Team Consortium at Massachusetts General Hospital. And in that organization, we've been able to set up what we refer to as pulmonary embolus response teams now in 20 different countries in the United States and 200 different hospitals, which allow people, when they come into the hospital with this relatively rare issue of having a major blood clot in their lung, to get immediate responses within a half hour with multiple specialists, either on the internet or in person. And from my standpoint, it seems to me that this is an approach that can be used for patients that have this rare disorder called porphyria. So porphyria is a kind of orphan disease, okay? It's caught in this medical fragmentation. Nobody owns it. Not a lot of people know a lot about it. And for that reason, the diagnosis is often missed. The porphyria community, being organized as it is in a position to influence how care in the United States occurs for people that have your type of disease. And one way this can be done is by helping to establish porphyria centers of excellence within the United States to ensure that there's an incentive that the appropriate care is given. And that incentive is the fact that if centers and physicians are designated as centers of excellence and members of centers of excellence, that patients would be by themselves or by their organizations or by other physicians directed to those designated centers that would guarantee that they would get the appropriate care. The other thing is that when I say directed towards centers of excellence, that does not mean and doesn't imply that patient or patients would have to travel a long distance to some major medical center to see some guru. But what we went on to do is to ensure that the physician in their hometown has access to the immediate consultation with the appropriate members of the team that would be involved in their care from long distance. This would be a series of different subspecialists that are involved in porphyria care and have the experience to make rational recommendations. The construction of such porphyria center of excellence would have to be multidisciplined. Mary showed you that graph, that picture, that cartoon of the symptoms associated with porphyria. People with porphyria present to dermatologists, they present to lung specialists, they present to hematologists, they present to GI people, and they present to rheumatology. Very often they are misdiagnosed. So by creating a centers of excellence, we would automatically assemble a group of physicians and other caregivers who have expertise in the field and make them available with short notice to the referring physician at the local center, the local hospital, to offer the appropriate advice for both the diagnosis and the treatment and the necessary follow-up, and be available during that patient's course, whether it be chronic or an acute issue, for further consultation as needed. And that it would be done as a team with a joint recommendation to the referring physician, allowing the referring physician, the primary care physician, to be the major doctor taking care of the patient and allowing the patient to stay where they live, so they don't have to travel back and forth long distance to be seen. The average patient that I see with porphyria travels between 3 and 4 hours to come to see me. And that is absolutely unacceptable. It is inconvenient. It can even be dangerous. So anyways, so I discussed the definition of the disease. We talked about the types of AHP just briefly. Explain why it happens, what the mechanism is, how the diagnosis is made, how you can prevent it and treat it from occurring, at least acutely, the complications that may be associated with treatment. And also, I've proposed to you, as members of the porphyria community, an option to try to improve care for others who have yet to be diagnosed. That's the end of my presentation.
Thank you, Dr. Smith. That was terrific. I learned a lot. Can we get you back on again before the questions? How do we get that slide down? We want to see Dr. Smith.
Stop the screen share. Let's see.
Dr. Smith and all of you might be interested that we are working with Dr. Smith. He is creating a centers of excellence criteria, and this was what the APF will use to award centers of excellence. And you also might want to know that the APF has entered into our board a psychologist, internist, emergency room medicine physicians, gastroenterologists, and a number of other related social worker, so that we can cover the criteria that Dr. Smith will be giving to us, and we'll be awarding those. And I'd also like to ask Dr. Smith some questions, because we've had many questions given us before this presentation, and now we're also going to, after he answers those, we'll see if he can answer some from the audience. One of them is very, very important thing that is happening. We have Givlaari, which is fantastic. Many people are having no problems with Givlaari for acute attacks, where many are still being treated with panhematin. But one of the problems with Givlaari is, and a good thing, is it lowers the PBG. One of the big issues for patients now is that their physicians are saying, no, you can't have panhematin when you have an attack because your PBG is low. Dr. Smith, could you speak to that? Many doctors are going ahead and giving them panhematin. Some doctors are saying, no, your PBG is low. There's no indication for, before we do this, I want to say that Dr. Ronnie is on from Mexico, and he is also on our board. Thank you. And Dr. Smith, can you answer that question?
Yeah, it's I think the question really comes down to how you make the diagnosis of an acute attack, as you know, porphyrins and prophylinogen can occur in the urine in a person that doesn't actually have porphyria. Now, this is and the amount of porphyrin that you find in the urine, or ALA that you find in the urine, can be related to the concentration of the urine. So if a person is dehydrated or ill, porphyrin levels become detectable and to a very low level. And so the question is, at what level of porphyrin do you consider that to be consistent with a recurrence of the disease or the diagnosis of the disease? And for a lot of us, we use a value that is 5 times greater than the upper limit of normal for whatever lab is being used. It also depends on how you make, what the assay is, whether it's done by mass spectroscopy or by high pressure liquid chromatography, and whether you're looking at a 24-hour urine result or you're looking at a random urine result and how it's reported. So there's going to always be, I think, a group of people that are going to have porphyrin that's going to be increased, but not increased enough to confirm a diagnosis. And that's where the problem lies, okay? What do you do with those people that have symptoms, but the porphyrin are barely detectable? Is that real? Is there a way to know that? And I don't think there really is, okay? But I think if you have a person that's on Givlaari and the doses that are prescribed does not totally suppress ALS formation. Okay, so you still have ALS activity present, and the activity of hematin is to suppress ALS. The activity of Givlaari is to interfere with its production. So they both affect ALS enzyme, but with a different mechanism. And what I would say that if, at least in my own experience, is that the failure rate to Givlaari is about the same as it is with hematin. It's about 30%, 20 or 30%. So if you have a person that has a disorder like acute hepatic porphyria, and they're coming to you and saying they have exactly the same symptoms that they had before, but they're on Givlaari, then I think the obvious thing to do, at least in my view, is to treat them with hematin. And now, if they had absolutely no porphyrin in the urine, I might think about it a little bit. But the truth be told, that most of them have some that you can detect. And so I really don't have much of an issue with treating people with hematin. Hematin is a drug that does have some complications associated with it, but it's generally very well tolerated. And if a person looks like they have an acute attack and they have the diagnosis of acute hepatic porphyria confirmed, then I just go ahead and treat them. The issue is, what do you do with the Givlaari? And so since the ALAS is not totally suppressed at the dose that's recommended, there's an option to increase the dose. And that's, people are doing that. There's no studies really that demonstrate that works, but people do it, and anecdotally, they tell me it works. I've never had to do it. I've never done it. And you can decrease the interval of administration, and I have done that quite a few times. And there's no question that I've seen people who break through on monthly administration. If I move it to every 3 weeks or 2.5 weeks, they come back under control again. And you can spare them hemotin under those circumstances. But it may take 3 or 4 or even 6 months for that effect to take place. Well, what are you going to do during that period of time? Let patients suffer?
Right.
No, you're going to give them hemotin for heaven's sake.
Yes. Thank you, Dr. Smith, because this has become a big problem with patients suffering because nobody's giving them, not nobody, but a lot of doctors are not doing it. Another question, if a patient is having liver enzyme problems, how can they be treated with Givlaari or panhematin?
Yeah, so that's
Because both have a problem.
yeah, but that's a non-specific question. So the presence of liver disease is not a contraindication to therapy with either one of them necessarily. It depends on how bad it is, right? I mean, so we know that Givlaari can be characterized by increase in liver enzymes. In the Envision study, there was 13% of people on Givlaari that developed abnormal liver enzymes compared to 2% of those people who were not treated with Givlaari. So we know that happens. But continuation of Givlaari under those circumstances almost always leads to further decrement in those liver enzymes. They just get better on their own. So that in and of itself I wouldn't really worry a whole lot about that. Same thing applies to the alkaline phosphatase, by the way, not just the SGOT or SGPT. But if you had somebody that had some underlying liver disease on top of it, I would be very hesitant to commence therapy with Givlaari. And the reason for that is pretty simple, and that is that there is at least a case report. In fact, I think it appeared on your website of a young lady with AHP who had liver fibrosis that was placed on Givlaari, and her liver enzymes increased, probably 100-fold, and the Givlaari had to be stopped. So I would be very hesitant to use it under those circumstances. Now, in terms of hemotin, hemotin is really a relatively benign product. And they would have to have really severe liver disease before I would not treat a person with hemotin. I mean, let's face facts. For people that have an acute attack of porphyria, there's a limited number of options that we can do. And giving just glucose or dextrose alone often is not adequate. Often people break through dextrose, and sometimes this breakthrough can be so rapid that you're faced with a person with neurological diseases that can risk their lives. So my view of this is if someone has an acute attack of porphyria, regardless of the setting, you need to treat them with hemotin. In terms of chronic hemotin therapy in the prophylactic setting, time will tell. Okay, lots of people do it, and I personally have not seen a major issue with it just yet in terms of liver function. So I would probably apply it under those circumstances.
Thank you. You touched on this in your presentation, but a number of people have said my coproporphyrin's high or my hexocarboxyporphyrin's high, and they're thinking that they are then diagnosed by porphyrins. Can you speak again, sort of quickly on just the porphyrin problem?
Yeah, so porphyrins, total porphyrins go up in many, many, many different types of diseases. Dehydration, a person with nausea and vomiting, a person with liver disease, gallstones, a person with a hemolytic anemia, a person who has B12 deficiency or folate deficiency. Anything that stimulates red cell production will increase your porphyrin levels in your urine, okay? So porphyrins themselves being elevated doesn't really tell you a whole lot, okay, when it comes to acute hepatic porphyria. Now, you have to be careful because when you think about people that have an acute attack of porphyria, if you have AIP as an example, the porphobilinogen levels tend to remain elevated for a prolonged period of time, perhaps months, and perhaps years even, you know. So in that setting, if you had a person had an acute intermittent porphyria and their porphyrins themselves were the only thing was elevated, I would start thinking about something else going on, okay? On the other hand, if you had one of those other types of acute porphyria, variegate, or perhaps a copra, those porphobilinogen levels fall very rapidly within days or several weeks, okay? But the porphyrin fractions stay elevated twice as long usually. So it's possible that you could have someone have some subtle recrudescence of porphyria with brain fog, as an example, rather than acute attack or back pain that's, you know, that's unexplained. And you check their urine values, but their attack was 4 days before or 5 days before or 2 weeks before, and the porphobilinogens have returned to normal, but the porphyrins are still elevated, okay? So you have to put it in context. Now, the other thing is, as far as anybody knows, the severity of the attack correlates with the elevation in ALD and porphobilinogen. So if you have a really severe, terrible attack that's just killing you, terrible pain, then you would expect the porphobilinogen to be very, very high. So the half-life of the drug in the urine can be a reflection of the total concentration that you find in the urine. The higher the concentration, obviously, the longer it's going to take it to clear from the urine. If you have a minor spurt because you have a little bit of back pain, and that's, you know, that represents your attack, but it's minor, the porphobilinogen in your urine is going to be slightly increased and it's going to disappear faster, but the porphyrins will still be there.
Interesting. You touched on this next question, and I'll just briefly review it. Why do providers, including nurse practitioners and physicians assistants, say they're learning all about everything in medical school? Why aren't they learning about porphyria? My answer was that there are 7,000 to 8,000 rare diseases, and it's very difficult to learn about all of them. So that us being one of those rare diseases, do you have anything to add to that?
Yeah, I do.
Okay.
I'm not too sure it's all that different, but in you know, I taught medical school here at the University of Pittsburgh for 7 years, and what I saw was over that period of time, was that the philosophy of medical education has changed. It's not the way it was when I was in medical school, and you know, basically the philosophy is that because of the internet, there is so much information that's being published on a daily basis about medicine that it's overwhelming. And so that at the medical school level, students are now taught basically a survey course about medicine, with the intent that as they go through their internship and their residencies and their fellowships, you know, over a 6 to 8 year period, that they will get greater and greater information with each layer of education. So it's not necessary for a person to know the details about acute hepatic porphyria when you're a second-year medical student, and that's why. So I don't personally agree with that at all. I'm old school. I think the more you know, the more you see. You know what I mean? The more you're able to to see things. But that's the philosophy in the education of medical students in the 21st century.
Thank you so much. Nicole, you have some more questions? Nicole, you're muted there. Go ahead.
Thank you.
She muted? Go ahead.
So, Dr. Smith, I've got a question from someone that has VP, and they want to know if the sunlight factor lessens as a person gets older by any chance?
Well, again, as I said earlier, you know, and especially in a female, the disease may change its phenotypic presentation due to lack of cycling as you get older. Okay, so in that sense, it could. The other thing is education, right? I think I drive more carefully as an adult than I did when I was a teenager, and I think when people have disease that cause blistering on their skin when they're exposed to the sun, that can be pretty miserable. They can get infected. They can be painful. They can scar. That over time they learn not to expose themselves to the sun. And we certainly see this in the EPP population of patients, where they have adopted their behavior based upon what the trigger is. And these are the shadow jumpers, as you know, and I think the same thing could apply to people that have variegate. Now, it depends upon how often you get the attacks, because when you look at the frequency of blistering in people with variegate porphyria, it's around 10%. Okay, and variegate porphyria, I mean, we're talking about rare diseases to begin with. Now we're talking about 10% of a rare disease. So it's a very small number of people. And the other thing is that the ones that I've seen, which haven't been that many really, but the ones that I've seen, when they do get these blistering attacks, it's not continuous. It's not something that occurs all the time. They are highly intermittent, and 1 month they have it, and they don't have another blistering attack for 5 years or something. So I would have to say that, with the exception of changes in behavior and changes in physiology that come with aging, there probably is no difference.
Okay, thank you. That makes a lot of sense. Thank you. The next question is, to what extent is autonomic neuropathy caused by AIP reversible?
Oh, interesting question. I was just in a meeting just a couple of weeks ago about this very issue. The short answer is I don't know. Okay. And the reason I don't know is because the neuropathy associated with AIP can be acute and it can be chronic. There is some emerging evidence. It's not totally clarified, but there's emerging evidence that even with short courses of a severe attack of AIP, that you can get permanent nerve damage that never really gets better, or at least returns to normal. And for those people that have reversible nerve damage, that's classic for porphyria. People who have this Guillain-Barré-like syndrome, where they have a descending paralysis, that it may take 2 to 3 years for them to recover enough to have normal daily activities, and they may never ever become normal. So it depends on whether it's acute. It depends upon how much nerve damage has been done during an acute attack. There's also evidence that, which I think is very interesting, that people that are hypersecretors, 30% of people with AIP at least, appear to be hypersecretors, where the porphobilinogens never really return to normal. They're always a little bit elevated. Those individuals, as far as I can tell, looking at the literature, don't seem to have neuropathy associated with being a chronic hypersecretor. So there has to be some other mechanism involved with this, other than just porphobilinogens and ALA being elevated. Okay.
Wow, that's great. The next question is, my family has BP and the R59W gene mutation, and I would be interested to hear how porphyria affects the eyes, and if there's treatment to treat, if there's treatment available for the scarring of skin on the people with porphyria. So two different.
Well, the eyes, you said the eyes, right?
Mhm.
So people with porphyria do have a predisposition to thrombosis. It's a minor predisposition, but they do have a predisposition to it. So you can get retinal vein thrombosis, you can get retinal artery thrombosis with it. You can lose vision because of that sort of thing. That I've never seen it myself. Okay, so I think it's pretty rare, but it can happen. Now, in terms of treating scarring in the skin, a scar is a scar, and removal of a scar would be, basically topical steroid therapy or a surgical removal of it. There isn't anything particular about porphyria that is any different than any other scar. When, once it's there, it's a chronic problem.
Okay. All right, and then we have a really good question here. I have very good porphyria and have had a full and complete hysterectomy. What are there any safe natural alternatives like vitamins or supplements that you can advise on that are considered safe for us special porphyria people, since they're thinking that other female patients with other types of porphyria and menopause might be struggling with as well?
I don't know. I actually don't know what that question means. If the question refers to, is there some vitamin I can take? Well, people that have porphyria can develop pyridoxine deficiency, which leads to very high homocysteine levels. That's been reported both in patients being treated with givosiran, as well as people not receiving it that have acute intermittent porphyria. So people that I've already mentioned, patients who have hemolysis have increased porphyrin production due to increase in ALS activity, which conceivably could trigger acute intermittent porphyria. So people that have vitamin B12 deficiency and folate deficiency have what's called ineffective erythropoiesis. That is where the red blood cells precursors are destroyed in the bone marrow. They never get out of the bone marrow at all. They're hemolyzed within the bone marrow itself. And as a consequence of that, you have stimulation of red cell production, okay, which means you have an increase in precursor formation. And even in the absence of overt porphyria, you can get pain from that. So if you're going to take vitamins, then what I would say is be sure that you're replete in folate and vitamin B12 and to some extent iron, okay, which you can be depleted from. So now there's no vitamin that I know of that actually alters the course of acute intermittent porphyria. All right, now there's naturopathic things on the internet where people make this claim, but in a scientific setting, they've never been demonstrated to work. So I would say number one is they're probably none of them are dangerous, so they're probably not going to hurt you, because there's millions of people. My wife takes multiple vitamins all the time when I tell her she's wasting money. It's a belief system, and there's millions of people that do it. So I don't think it's going to hurt anybody. And it might help if you're depleted, but it's certainly not going to change the course of porphyria.
Okay.
I have a question about food that we get almost daily. People think that if they eat a certain food, that it could be porphyrogenic and cause attacks. I'm not sure that these are attacks. It could be some digestive problem. Before I ask the question of you, on the APF website is an entire section on diet and nutrition. It also talks about food, and the gist is that that if there were porphyrogenic foods, that you would have to eat like a whole field of them. But I'd like to have your opinion. Are foods causing attacks?
Not that I know of.
Yeah.
Not that I know of. You know, but I think you're touching on a point though that is important to emphasize, and that is that one of the problems I have in my practice, since there's a lot of docs that really want me to see these patients because they don't know enough about it, and I'm there to deal with it, and so I see a lot of patients that come in with the presumed diagnosis of porphyria, and it's not from their family doctor, it's not from their some other physician, it's from Aunt Bessie, or it's from surfing the net. And the two most popular diagnoses that I see now in my clinic, which is a rare hematological disorders clinic, are people that self-refer for porphyria or for something called mast cell activation syndrome. And that's because these two diseases have multiple symptoms that could be anything, and people get on the internet and they sort of read these symptoms, they put it together themselves and come in, they are absolutely convinced they have it. And part of the responsibilities that I have as a physician is to, I don't want to say dissuade them of that, because who knows, they might actually have it. And you have to, but it is to be as thorough as you can to either make a diagnosis or exclude it. And so there's a lot of people that are seen in gastroenterology, as an example, and then come to me with severe irritable bowel syndrome, who have this terrible abdominal pain. They've been on the internet, and by God, they know they have porphyria. It just can't be anything else. and it usually isn't. I mean, it's a rare disease, right? I mean, so it usually isn't. So when people come in and say that, they get upset when they eat a certain type of food and stuff, they probably have esophageal reflux, or they have gallbladder disease, or they have something else, most usually.
We have that a lot as a question. Can we take a look at some of the, would you answer a few more, or at least one more?
Yeah.
I know we've taken over an hour, but also a number of people want to understand why they're having this horrendous pain. And many of them are called drug seekers. They are called hypochondriacs. What would be a good response? Because this is happening to people who really do have porphyria. It's happened to me. It's happened to Nicole. It's happened to probably most everyone in this audience. How best can we respond when this is said to us? And you touched on the reasons that we're getting these symptoms, but you might touch a little more on this.
Yeah, so it's a real problem. It really is a real problem. Like I said, I have this lady who's 75 years old who has porphyria, and she's been told her entire life that she has fibromyalgia or something else. Just one diagnosis after another, and that's where I think that's why I think this idea of some semblance of a centers of excellence comes in, because under those circumstances, people focus on that particular disorder. That I'm talking about, the caregivers focus on either excluding or confirming that particular diagnosis. And plus it takes people out there in the community, and at least those that see these kind of patients, and it allows them to be educated as time goes by their interactions with the Center of Excellence. I think there's two tensions that go on here. One is that there are individuals out there in the real world who have convinced themselves that they have porphyria, and there is nothing ever that's going to change their minds. And they are exceedingly aggressive about it. And they just shop from one doctor to another, to another, to another, until they find someone that's going to tell them what they know they already have. I think that's a mistake. I think that leads to misdiagnosis, and that can ultimately harm a person or their family. But I think the other part of the tension is, again, that we've talked about before, and that is it's a rare disease. And as a consequence to that, there's a lot of doctors out there that really don't have the slightest idea how to make a diagnosis. And when they do know how to make the diagnosis, or what to do to make a diagnosis, they don't know how to interpret the results. You know, so that gap has to be closed. And part of I think the responsibility of organizations like yours and what I do is to take those individuals that don't have this disease but think that they do, and readjust their thinking to reality. Now, I clearly don't know exactly how you would go about doing that, but you can't let someone go through life convinced that they have a disease that they don't have, because they change their lifestyle for it. That gets passed down to their children, for God's sakes, you know, et cetera, et cetera. It's a major impact on a family. And the only way I know how to do that is a slow progression in terms of education. And the American Porphyria Foundation is a perfect place to educate people about what porphyria is and what it's not.
You know, we just got a note from a person in South Africa who says, my daughter, the doctor wanted to put her on antidepressant.
Yeah.
And said it was all in her head before she was formally diagnosed.
Yeah.
And that also happens in reverse, not just the patient, but the doctor is also convinced. And there again, education is the answer. And by the way, for those of you out here who have never received the doctor packet from the American Porphyria Foundation, we have a packet full of comprehensive information for you to give to your doctor. You can also give us your doctor's name and we will send educational materials, because that's how you're going to get diagnosed properly, or they'll find out that it's not porphyria and look for something else, because that's also a problem. As Dr. Smith said, if they're going down the wrong road. For those of you and there are many questions that have not been answered today, we will collect all these questions. We will get them answered for you. Do not worry. We will get them answered for you. I have one more thing here. I've been, it passed. I didn't see it. My sister's had many negative tests. I have a positive for AIP. There again, your sister can get all these diagnostic tests, and including we do have a link for DNA. Again, that's not the way to diagnosis, but it will validate what your doctor's thinking. Dr. Smith, thank you so much for everything, not just for today's talk and answering all these questions, but for everything that you've been doing. And we promise you that we're going to get on this criteria we're going to get on this Centers of Excellence and make sure that we have those ready for patients by the end of the year. Thank you. You're getting all kinds of people saying thank you to you. It's rolling on and on. So thank you again, Dr. Smith. And we will go from Dr. Smith to Mayra Martinez, who will be giving a presentation about the type of porphyria AIP that she has and her grand adventure. And I think that you will learn a lot, not only from what Dr. Smith had, but also from someone who has it. Mayra, would you like to go ahead?
Hi, everyone. Yes, thank you very much, Desiree and Dr. Smith. Thank you so much for that wealth of information. Where were you when I needed you back in 2017 to learn about this? So my name is Mayra Martinez. I am actually fairly new to this community. I was diagnosed with acute intermittent porphyria in March of 2021, but I had to go through hell in order to get diagnosed. And I want to show you some images of what I experienced in order for you to be able to follow along. So this was me, very happy and wonderful before porphyria ever showed up. Can you guys see it okay?
I can't.
No.
Can you help her?
Yeah, let me see.
Hold on.
It says that you started screen sharing, but it's blank.
Oh, it is going. Hold on. It is.
Oh, there it
thinking.
is. There it is.
Okay, there it is. Okay, so I'll go back. Okay, so I was very healthy, very high energy, full of life, and never ever had actually even heard the word porphyria. I was actually shocked to learn that there was such a thing. So I actually ended up going through some horrific things at the beginning of 2018. I started the year with the worst of the worst stomach pain. Had no idea what was actually causing that pain, but everything from my stomach to my internal body, I felt like I was actually being electrocuted. I had so much pain, regardless of how much medication I was given. The pain would not go away. The one thing that I can tell you, pain, no matter what I did, it just, instead of getting better, things got absolutely worse. In fact, I started having issues with my breathing as well during this time. So they actually had to put me on that. Long story short, during that whole hospitalization, I was in the hospital for a whole entire week, and they determined that the closest diagnosis was that I had really bad back pain and I needed to have an L5S1 fusion, which fast forward to April of 2018, a few months later, 4 months later, I ended up submitting to the surgery thinking it will finally take my pain away. I had had back pain for over 5 years. I changed my everything. I changed my style of my lifestyle from what I did for a living to exercising harder and making sure that I ate better. And I turned my whole entire life around from a wellness standpoint, thinking that I could avoid this. And I couldn't. So I submitted myself to the surgery thinking it will absolutely take care of everything. What I didn't realize is that that was actually going to lead to more problems. My immune system got weaker and weaker. As a busy mom, as a busy executive, I had high stress. I was a vice president of talent acquisition for a construction and engineering company. So the stress level was consistently really high. But I didn't realize that going through this was going to just make the situation even worse. So fast forward to later, I ended up having, I'm sorry, this is going a little too fast. I ended up having problems with my fingers. I started experiencing shake in my hand. At the beginning, it was just my right hand. I noticed it when I was putting in my contacts that I had a little tremor. I started going to physical therapy thinking it would just I would be able to do something that would make it go away. Well, it didn't go away. Instead of going away, it actually got worse. My tremor in my fingers not only went from just a little light tremor, now I was doing one of these, and actually with both of my hands, I looked like a Parkinson's patient. Fast forward to later on, things got even worse and I ended up being intubated. I'm fully paralyzed, went fully paralyzed head to toe, December of 2018. Doctors had no clue what was actually going on. They thought it was just nothing but stress. So the day that I was actually being sent supposedly to acute rehab, to be able to get me out of this deep paralysis, I ended up being intubated, being sent to ICU. And because my throat muscles were not engaging properly, instead of the food going down the proper pipe, it was going straight to my lungs for 3 days. It caused the worst pneumonia I ended up intubated, and while I was intubated, they finally began a series of tests for the very first time, looking for things outside of just stress. Because keep in mind, during the whole entire year, 12 months that these doctors had the opportunity to help me come up with some sort of reason why I was going paralyzed. We couldn't, because everything just kept on going back to just stress. They were finally starting to look for tumors, for cancers, for all sorts of things, but they came up empty-handed. Finally, after 9 days of them trying everything you could possibly imagine, I'm intubated, I'm completely out, but I had an outer body experience. Conversation for a whole other day, because I don't have all the time in the world to tell you everything I experienced. But while my husband is planning my funeral, along with all my family who flew out from the East Coast, I live in San Diego, California. They all flew out to San Diego to say their goodbyes. They decided to do one last thing, and that was a Hail Mary of doing plasmapheresis. I'm so glad that they did, because I was able to recover as a result of it. Nothing but just, hey, this is the last thing we can possibly do. If it works, great. If it doesn't, we're going to have to put her on hospice. And I'm a Christian, so I will say it. To God be the glory. I am here and I'm alive, and that actually really helped be able to get out of the coma and be able to start a recovery process. So this image here, you can see I'm actually getting my last treatment of plasmapheresis. I got 5 of those. And then that began the start of my recovery period. And I'll show you some images of relearning how to do life all over again, from relearning how to breathe, how to talk, how to walk, how to do life all over again. And as you can see, I can actually do pretty much everything again today. But man, it took a lot of work, and it continues to take a lot of work to be able to do this. So here you go. Look at these images. I have no music there, so you could see on purpose. So everything is a struggle here. My muscles can hurt every single day as I'm doing these exercises. I have a dropped foot still that I have not been able to recover. As Dr. Smith mentioned, sometimes it can take long. I don't know that I will be able to recover at this point. It's been 4 years now, but I believe that with a lot of exercise, I will be able to. So I continue doing these, what you see here in these images. I do these exercises still today, even though I do have muscle now. I've been able to regain some muscles. I still have to redo it every single day. I was at my worst 72 pounds, 72. So everything that I've had to earn and redo, I've had to work really hard for today. Those images, the last few images, I want you to know, have I gotten better to the point where I can avoid attacks? No. This is a recent image, and yes, I'm a crybaby. That is my mother. I still have attacks, and my mother still comes to my rescue whenever I have these massive attacks. I've had 27 attacks in the last 4 years, and now we know that they have been attacks we didn't know for a really long time. So I've only gone on this journey of learning about porphyria the last 2 years, and it's been a challenge. I've had to pivot my career as a result of porphyria. But I'm not letting that get in the way. One of the things that I have found extremely helpful is porphyria community. Having found Desiree and the entire APF team has allowed me to be able to build a community where I don't feel alone. Yes, this sucks to have this illness, but when you have a community, you're able to get through your day, you're able to rely on other people. And I belong to a group of 3 other people where when we feel horrible, we text one another, and we feed off each other's energy. And while I might be in the middle of an attack, they are not, but they know what I feel. So they're able to send me messages, giving me words of wisdom and words of advice on how to deal with my situation, or just encouragement. So I want to leave you with this last image, and that is me today. Yes, porphyria is horrible. Porphyria can change your world. It certainly changed mine drastically, but I'm not letting that get in the way. And I want to encourage you today not to let an illness impact you to the fact where you no longer recognize yourself. You have stopped living as a result of the illness. You can continue to live. You can live a meaningful life regardless of what you have. And if you're a caregiver, know that what you give, your feedback, what you're constantly feeding the person that you're taking care of, it really makes a huge difference. I am beyond fortunate that I have a husband who is incredible. A lot of people have seen a lot of images. I put out a lot of content about porphyria now, because I was once upon a time a person that did not know anything about the word porphyria. In fact, when I was in the process of getting diagnosed, my neurologist said, do you know what porphyria is? And I said, no, I know porphyrio, but I don't know porphyria. I'd never heard of it before. So I'm on a mission to educate as many people about porphyria, and I would encourage you to do the exact same thing as well. Any questions, comments?
Wow. I think most of us are just overwhelmed with the inspiration that we've just seen and heard, and appreciate so much. Mayra has, from day one, Mayra has been out there educating the community on her story, which is interesting in that Mayra also takes both Givlari and panhematin. She continues to have attacks, but no matter what, as soon as she's finished with the attack, she's back in the fray. And I personally appreciate it, and we appreciate the involvement that you have. Mayra is one of the member advisory board. I don't know if all of you are aware that the Porphyria Foundation has a member advisory board. We review the things that we should do and not do, and we also always ask for your suggestions. Please reach out to the Porphyria Foundation, and people like Mayra will be reviewing those suggestions, and we try to implement what you want, our members want. Thank you, Mayra. I'm so glad we have all of this being recorded. Our next presenter is also patient Sharon Dill, and Sharon lives in Florida, and she too has been through an amazing journey. Sharon, can we ask you to come on the screen now, or to get started, and you'll be there? Unmute Sharon. Hello. Can we get Sharon on? There she is.
There we go. I was going to try to unmute.
Can you unmute? Can you unmute Sharon?
Yeah.
Can you unmute Sharon?
Yep. I'm doing it right now.
All right, you're doing it. Okay. Can she unmute herself?
I tried to unmute her as well. It's not letting me, so I'm
It's
guessing.
not letting us unmute you. Sharon, can you go to the bottom of the screen and unmute you?
Because I can't do it.
I can't.
Well, can we unmute everybody? Can we just unmute everyone?
Let's see. Let me see if that's pot.
We can ask everyone to unmute, but that would still
Yeah,
be on
that's
there.
still. All right. No. Oh. Sharon, can you ask to unmute? Okay, now we can't get Sharon. Oh, goodness. Wouldn't you know? All right. Sharon, while you're getting unmuted, would you, Mayra, would you like to, excuse me, Nicole, would you like to be playing Megan's video, and then we'll see what we can
Sure.
do to get Sharon. Sharon, you can, if you'll look at the bottom of your screen, Sharon, there's an unmute button. No.
Well, let's see if she can maybe
Uh,
go off and come back on.
Yeah,
Megan
Sharon.
Parrish. Oh, sorry.
Yeah. Hold on, Sharon, while you're getting unmuted, we had this once with Mr. Do you remember that? While you're getting unmuted, Sharon, we'll go ahead and play the video of Megan.
So Megan Parrish wanted to be here today, but she couldn't. So she was kind enough to make a video. She's got an amazing story. I'm just gonna share my screen and let her tell you because she is great. Here, let's do this.
Hi, my name is Megan. I'm 35 years old and I have acute intermittent porphyria. I was diagnosed with porphyria in 2006. I had been experiencing symptoms for about 6 years prior to my diagnosis. It was a pretty long journey. My mom was, my cheerleader, and she just took me to every doctor that we could get to listen to us. And finally, when we got an answer and it was porphyria, I really, expected that there was going to be like this instant fix, like where's my pill, where's my cure, where's whatever it is, just fix me. But very quickly realized that that's not how this was going to work. So at the time, early 2006, Facebook wasn't really a thing, and the internet and the resources that we have now weren't necessarily as available or as accessible. So my mom did tons and tons of research and spent hours on the phone with people from the American Porphyria Foundation and just trying to get every bit of knowledge she could to help me. And so for a long time, I was able to kind of alter some medications that I was on because of misdiagnoses, and just some lifestyle changes and a healthy dose of just, for lack of a better word, just me not wanting to believe that this was happening, that I could just kind of push it out of the way, I could tough it out and denial, but I did okay for a while after high school, and I went on to college and
Nicole, we cannot hear the video.
Should I put, how about now?
I couldn't feel my legs and hands.
Yes, okay.
Should I put it back?
At one point, I was having seizures and I spiked a fever over 104 degrees, and they, packed me in ice. It was a very traumatic experience for me and everybody involved. And I think that was the first time that I really realized how serious porphyria was, and that I couldn't live in denial for the rest of my life, and that I was really going to have to take it seriously. And so for the next pretty much 10 years, I spent my life tethered to an IV pill for, I'd say, anywhere from 50% to 70% of my time. 3-4 days here in and out of the infusion clinic, 3-4 days here, inpatient stays, to weeks to sometimes over a month long inpatient stays. And so it was very, very difficult not getting to live a normal life like many 20-year-olds get to do. And I really struggled with things like depression and anxiety and just feeling very, very lonely and hopeless. For me, I think, the big moment for me, I found the American Porphyria Foundation Facebook page. I knew the Porphyria Foundation had existed. They had helped me and my family out numerous times throughout the years. But when I found the Facebook page, I made contact with some really, really amazing people in the community who helped me know that I was not alone. And they saved me and pulled me out of some of the darkest moments of my life. And they're still some of my greatest friends today. And so over the last 10 years, I've, slowly but surely improved year by year somehow. With the help of my medical team, we work together and, we figure out what works and what doesn't work for me. And it's a game of trial and error sometimes, but fortunately I got lucky right at the beginning of the pandemic, and things really, really started to take a turn for the better for me, which was fortunate because, medical care and everything was just so chaotic. You didn't really know what was going to happen. And so, I was kind of gritting my teeth and, looking over my shoulder, waiting to see what was going to happen next. But slowly but surely, I just, one infusion here, and then I would go weeks at a time, and, only need treatment here and there with different things. And, I got to ease off of some of my medications for my symptoms. And the next thing you know, I was going months at a time in between, treatments and visits to my specialists. And now here I am, and it's been over a year since, almost 2 years since I've needed to be inpatient, like admitted for an infusion in the infusion center, and it's been, I think, 4 years since I've been admitted inpatient to the hospital. So it's incredible for me to think that I've come so far, and it's almost unbelievable from where I was. It doesn't seem real some days, and I finally got to the point now where I don't look over my shoulder, and I'm enjoying life and getting to live a little bit more normal and getting to enjoy things that I've missed out on along the way. And yeah, so I'm so grateful for everything that I've been given in the last couple of years, and the opportunities I've been given to get to help other people in their journeys. And if I could bottle this little bit of joy that I've had in the last couple of years and give anybody else in the community hope, I mean, that would definitely make my journey, worth it. It would it would make the experience not in vain. And so I just wanted to come on here, and sorry I took a little more time than I expected, but happy Porphyria Awareness Week, you guys, and here's to the whole world knowing about us, guys, and we're going to bring more hope to us. I know it. I can feel it. Bye.
Thank you to Megan. What a wonderful thing. And what's wonderful also that Sharon Dill is unmuted, and I want to take a moment here to mention that there are several people on this call who had thriving careers, including Nicole, including me, including Mayra, Sharon. Many of you had very thriving careers, and these attacks changed our way of life. We maybe didn't have that career, but we had to go another path. For mine, it was the Porphyria Foundation. For some of you, you may be in the middle of finding your way. So I want Sharon to share her incredible experience. Sharon is very knowledgeable, and we're glad that you're here, and we're glad we can hear you, Sharon.
Thank you. And I do apologize in advance. If you hear little grunting or snoring sounds, that's actually my little dog Mason. So he is a snorer and he goes wherever I go. Before I talk about me, just one thing. If you haven't had the opportunity to meet Megan, I will tell you she's even more impressive in person than a video could ever portray. And one thing she left out is her tireless advocacy in porphyria and porphyria research and awareness. And I think that we are where we are now in large part due to people like like Megan. And I know she wouldn't say that. So brief background. My life was fantastic. I had the house and person of my dreams. I had my dream career. I was an executive human resource officer for a very large, about 1,000 employee oncology practice, about 100 physicians. And actually this week marks the 7-year anniversary of when I woke up one day with a pain in my side and really didn't know that I wouldn't get better, but I did a bit. So I don't want to really talk to you about all of my trials and tribulations, but to just say that it did take away my career, everything I love doing. I was very active in sports and everything. But what I do want to share is the things I've learned that have made my life better and more doable. One, and the physicians talked about this a little bit, is that don't be so set on the fact that you have porphyria if you haven't had a true diagnosis, because it robs you of the opportunity to truly find out what's wrong with you. And 99% of the time, there really is something wrong, but it may not be porphyria. So just be open to that. The other thing, and again, this was touched a little bit on that, stay off social media. I don't mean like the Porphyria Facebook Foundation and things like that, but to get your answers. And don't ask other people. Sure, it's great to say, hey, do you have this? Do you have that? But don't ask them about what medications you should take. Don't ask them what medications are safe or unsafe. The experts are there for that reason. And I can guarantee you, the person that you're talking to on Facebook is not the right person to ask, unless it's someone like the physician we just talked to. So stay off of there for your answers. You need an advocate. You need someone who is going to be as passionate about porphyria as you are, or as close to it as you can. Someone who's willing to learn about porphyria. Someone who is willing to crawl into a hospital bed with you at 2 o'clock in the morning because you're in so much pain, you just really don't know what to do. The person who's going to then show up and go toe to toe with the physician. And you need to have that person. It doesn't matter who they are. And maybe it's more than one person, but this is too hard of a journey to go through by yourself. And you just really need someone who's going to be there with you every step of the way. Don't go to the emergency room. So many times I hear stories and Facebook posts about, I went to the emergency room and they wouldn't do anything for me. Of course not. That's not their job. Their job is to stabilize you and get you admitted, or stabilize you and get you discharged. The emergency room is the worst place to go, because what do you want them to do for you? They're not going to give you the pain meds you truly need, because we all know about the crackdown on opioids and everything else. And it doesn't matter what your diagnosis is or what you're telling them your diagnosis is. Remember, they haven't even heard of porphyria. So that's the worst place you want to go. which leads to my next thing is do plan ahead. What I have found is the best thing that has worked for me is to make sure I work collaboratively with my physician, my treating physician, to say, hey, if I have an attack and I need to go to the hospital for inpatient treatment, how are we? And the key word is we. How are we going to do that? What hospital does your physician have admittance privileges? What is the protocol that they're going to put in your chart for pain management, nausea, panhematin, whatever is the medication that's going to work for you? Don't do it on a wing, because you will end up in ER hell and then blame the ER physicians. So you got to be prepared. And part of that is work together collaboratively again with your whole medical team, whether that's your primary care, your hematologist, your gastroenterologist, your OBGYN, if you're a woman. And they have got to be willing to work with each other, because there are things that are going to come up. One of the questions was about menopause. Had a complete hysterectomy. What do I do? Well, let me tell you, it's not easy then to find a medication or treatment that is going to help those horrible hot flashes. That's not going to make your porphyria worse. So who do you need to include? Your GYN, your treating physician. And in my case, it was one of the specialists who will forever be in my heart. And I know Desiree, Dr. Bloomer from University of Alabama, Birmingham, who is unfortunately not with us anymore. But there are going to be times when you're really going to need all of those physicians talking to each other. And if they're not willing to do it, go find someone else. My gastroenterologist retired, so I needed to find a new one. And when I went into his office and I introduced myself, and I said to him, I said, okay, so I'm a zebra, and we need to talk about what that means. Because in medical school, they tell you when you hear hoofbeats, think horses, not zebras. Well, we're zebras. And I interviewed him to make sure he was willing to deal with the variegate porphyria protocols and treating and any drugs or consultations, and that he was willing to learn what that meant to take good care of me. You have that right. We all feel bullied or pressured by the people in the white coats, but remember, they work for you. And if they're not working for you the way you need them to, find someone else who will. See, I think the last thing I want to talk about, or the last two things, is participate in research. Participate in research. Desiree can tell you how passionate I am about it. When I first got diagnosed in 2014 and started participating in research the next year, people would say, why are you doing that? There's never going to come anything that's going to help you. You know better than anyone working in the medical field how long these things take to get developed. And I actually did a presentation one time for the APF, and I had a picture of my nieces and nephews. And I said, I'm not doing it for me. I'm doing it for them. Because Lawson, who was about 8 at the time and is now 15, said to me one day, Auntie, am I going to get sick like you? It broke my heart. And I promised him, I said, Lawson, I don't know, but if you do, by then, there's going to be such better treatments for you. It will be okay, and you can live the life you need. And he just looked at me and he said, okay. And so now at 15, I can tell him it's true. And then the last thing is own it. I know we get frustrated when we go to a doctor and we say, I have acute intermittent porphyria, I have variegate porphyria, whatever the type of porphyria is. And they're like, what's that? And that was brought up in one of the questions is why don't they know about it? And I love the answer because it's not possible. Think about your career and your profession. And I was a human resource executive, and I prided myself on knowing a lot of things and keeping up to date. But I can promise you, I didn't know everything, and I would have to look it up. So why are we expecting nurses and doctors to know everything at the tip of their hat? So we have a responsibility to own that, for us to learn, and don't take it as a negative. What do you mean? How can you treat me? You don't even know about porphyria. Oh, okay, let me tell you some things. Let me get some information from American Porphyria Foundation or the Porphyria Consortium or wherever is a reputable source. Don't bring in things from Dr. Google. I have yet, actually only one physician, and it was the ER physician the first time I went there, who wasn't excited for me to be able to share information with them. These are people that know they want to learn all the time. And if you approach it the right way, again, as a partnership and in a collaborative way, as opposed to what's wrong with you? Why don't you know this? I actually had an anesthesiologist tell me one time that she did actually have a class on porphyria, a whole class session. And I was so impressed until she told me, and Desiree, I'm glad you're sitting down, because she said that what she learned and everything was from the film that the instructor showed, The Madness of King George. That was her whole
That's bad.
about porphyria. So use it as an opportunity to educate and give the world for the next person. I will tell you today, I'm not cured. I'm not 100% better. I do take Givlare, and it has changed my life. For some people, they've told me that they don't even think they have porphyria anymore. It's been such a 180. I'm not there, but I'm not sitting on my couch every day crying, thinking, what am I going to do? I have good days and I have bad days. I love the good days, and I never thought I would do anything like play pickleball because of my, my state of health. But I play pickleball, I ride my bike. I'm going out to Seattle to see Lawson and his sisters in a couple weeks. And I'm not going to be the auntie that just takes them to the movies. I'm going to be able to go out on hikes, go to Lawson's. He's a high school track athlete, go to his track meets and participate more than what I ever thought I would do that day 7 years ago when I got up and I said, I have a pain in my side. So that's my story, and I'm sticking to it.
Well, it's a
Sharon,
great story, Sharon, and we
wonderful.
thank you for all the tips, and we will use those tips on Porphyria Awareness Week that has Tip Tuesday, and Let's Talk Porphyria. Thank you. One of the things I do want to clarify is that the APF has a toolkit for when you do go to the emergency room, when you do go to a primary care physician. And we also have emergency room guidelines right on our website. And we have the doctor packet. So if you are armed with appropriate information, the doctors are more likely. If it is a medical journal, they're more likely to take that. Many doctors, and I'm glad you touched on this, do not like for patients to come in with stacks of things they printed from Google. That has been a complaint of primary care physicians who contact us. I do want to also clarify emergency room. You're right, many people go to the emergency room thinking they'll get diagnosed. That is not the place. You are so right for diagnosis. But if you are having an attack and you can't get into your regular doctor, that is important to get to that emergency room. And if for some reason they're not paying attention to you, call the APF. We talk to emergency room physicians all the time. We also have a warning card to carry in your wallet. And I'm going to touch on research. Our first motto is patients first. And many a time we've had grants to write or something else to do, but we will say to our staff, the first thing every staff member hears is patients first. Take care of that patient, then go on to something else. The other one is research is the key to your cure. So we're always finding volunteers. Right now, we're in the middle of finding volunteers for the disc medicine EPP trials and for the longitudinal study. So we are so grateful to people like Sharon and Nicole, well, actually many of you here who have been research volunteers. The APF also has a 40-year history. We're 17,500 people strong now. That's hard to imagine. We're growing by 20 to 30 people a day. Do they all have porphyria? No, probably not. But do all of them think they do? Yes, we're here to help you find out if you do or if you don't by providing the right information to you. So Porphyria Strong, take this week to participate in all the activities that will be going on, including tomorrow, Satisfy Your Soul Sunday, take a rest, commune with God, do whatever you do on Sunday to help your soul. And then Monday, we're going to have Motivational Monday. We'll have things and activities to motivate, including we have a fantastic new video from Andrew and on acute intermittent porphyria. We also have EPP videos. We have PCT videos we'll be putting out. On Tuesday, we have Let's Talk Porphyria. On Wednesday, that's with Nicole, and you can join that Zoom. It'll be talking about the roadblocks as well as the tips. Wednesday, we have Wear a Hat Wednesday for EPP kids, and we are asking that their schools allow all the students to wear a hat, and they let the EPP kids come in and talk about EPP. On Thursday, I'll be going to it's Thursday something, I've forgotten the name of it, but I'll be going to talk in front of congressmen and legislative health aides about the Orphan Drug Act, as I was one of the early pioneers of the Orphan Drug Act, something I look back on with great pride. We got that act approved, which changed the whole world of rare disease. And then I was in the middle of spearheading an effort to get the very first orphan drug, which was panhematin. And then Friday, we're going following Saturday, wear purple with great pride. Wear your purple to show the world about porphyrus, meaning porphyria in Greek. And we thank all of you for coming. If any of you want to stay on and ask further questions that we can answer as points of education, we'll be here. Thank you for participating. We appreciate every one of you and call you family in our porphyria, in our giant porphyria family and community. The APF welcomes you now and in the future. Bye, everybody that wants to go. Any of you that want to stay and ask questions, you're welcome. Unmute and you can ask a question. Is there anybody that has a question they'd like to ask? Oh, I see Dr. Smith. Dr. Smith, thank you for staying and hearing this, all of these great testimonies from all the patients. We appreciate that.
Thanks, everyone.
You're welcome to unmute if you want and ask your questions. I have a question for anybody that's remaining. Is there anything that the APF can can do that you feel would be more helpful? Where are we missing things? Does anybody want to put forth a question? I mean, a suggestion?
Hi, this is Jen. I just have a quick question on the
Sure.
age of, can you hear me?
Yes.
What is the age that, I guess, the youngest age you've seen or heard of a kiddo experiencing symptoms with AIP? My husband is confirmed diagnosed with AIP along with genetic testing, and all three of our kiddos have been positively identified as having AIP. None of them have shown symptoms except for our middle kiddo now. He's 9. And it's kind of when Dr. Smith was going through his presentation, a lot of those symptoms, and it happens intermittently, the abdominal pain, sort of this lethargy. I saw some people say swallowing issues, but he has some swallowing issues or throat pain at the time. It's just like a lot of vague symptoms that we're pursuing, and actually are seeing, thankfully, a hepatologist tomorrow for the first time. But just wondered if we want to make sure we're also going down. We know that genetic testing of AIP positive doesn't necessarily mean this is what is going on with him. So just curious if we're, being 9 years old, and especially a boy, if this is plausible.
Ask Jenny to come back.
Dr. Smith, would you like to, if you're still on, would you answer that question
Yeah,
about age?
yeah, it's quite possible that that he's having symptoms of AIP. The youngest age that children can be diagnosed with it is at birth, and it's an incidental diagnosis, but it can be done that way. And the age of presentation is often related to the penetrance of that particular person's porphyria, and so it's quite possible.
This is Carol Wood. Can I talk?
Yes, go ahead.
I am so grateful. My daughter's 53 and she first showed signs at age 4 months of age. And we were military, so I got sent to the best facilities in the United States. And it took until she was almost 20 to be diagnosed.
Wow.
Her brother, who's 4 years older, had it his first year and then sort of went dormant when he was 3, and then activated again when he hit puberty. She did not get diagnosed until her almost 20 years old. We've screwed up. It's been 30 years and we've been trying to find out, even though we knew about you guys, and Jenny has read the books and we've done everything. Jenny, come on.
I'm coming.
My daughter walked away and I got her back now. She's been here the whole time. This is Jennifer.
Hi.
The doctor just said,
What?
the doctor just said that it can start at age birth.
Good.
And we've been told exactly the opposite for 30 years, that you cannot have porphyria if it started as an infant.
Well,
Is there any, I guess, triggers or, it's hard to tell. Like my husband's latest attack was, which stemmed our genetic testing for our kiddos, was doing intermittent fasting and then going into ketosis, which obviously a low carb diet is not the way to go, and thus and learned there. But for kids, is there triggers because he's maybe growing so fast and not eating as much carbs or eating in general as much? Like what, it happened. His abdominal pain has been happening for about 6 months, but it was happening maybe once a month. And now it seemed like at least, if not twice a week. And so just trying to figure out what we can do to help, eliminate some of these symptoms for him.
Jennifer, her entire school life has never been to a Halloween party. I have a whole closet full of Halloween costumes.
Stress is a major factor.
And fact is, anticipating something is worse than dreading it, because she avoids anything she doesn't want to do. But anything, if we take a cruise, she never leaves the room. She's sick the whole time. And this is from 4 months on. If she went to visit her grandmother, she would have such a bad attack that the grandmother would hire a nurse to come in. And this is as a toddler, as a 3-year-old. When she was 18 months old, it was her 3rd hospitalization. and they said they were going to run tests and told me to go on home and get some rest. I made the biggest mistake of my life. They took tests, but they drew blood out of her arms to her veins collapsed, then out of her legs to her veins collapsed, and then they did her neck. When I walked in the hospital the next morning, I had taken in a happy baby and I picked up a terrified animal. She wouldn't let me dress her or anything else. Since then, she's had panic attacks and PTSD, which has aggravated everything.
At 2 years old, I started having heart pain.
Yeah, she'd say, "Mommy, I'm having a heart attack." But my kids, both my son and daughter, have diagnosed or described the pain in their stomach as knives cutting through their stomach. Knives cutting through their stomach, and they both the same from infancy. And
I'm gonna interrupt just a
Sure.
minute. Carol and Jen, we now have wonderful treatment. If you will call me, we found out that we don't live far from each other. We
Isn't that
will,
wonderful?
yeah, we will, I will get information to you about these treatments, and hopefully that'll help. We need to go on to others. Is there anyone else who has a, yes, Elizabeth. Elizabeth Peterson happens to be my sister.
Hi.
Deborah on here, I think.
I have a question. I believe a lot of doctors are under pressure. I don't know whether it's from their hospital or insurers or just the societal situation. They're under pressure now to reduce these prescribing of opioid medications. And of course, you know, for the porphyria patients that are dealing with unremitting pain, this can be, you know, just maybe something that is very unfortunate. And I didn't know whether Desiree or whether Dr. Smith would like to address or talk about that.
Well, I will say something very quick. I think that the baby in the bathwater is a great adage for this particular problem, because there are people who have very severe chronic pain. I'm one of them. And my porphyria pain the chronic pain has been complicated by getting shingles over and over in the same spot. But that it is a big problem. We have been part of the government's pain programs to try to help people that are having issues with getting pain med. And I think it's a real serious problem, but so is unwarranted addiction. So Dr. Smith, do you have anything to add?
Well, only that there is indeed pressure to reduce opioid use, and it's severe. I mean, I think if you just watch the news, you'll see every now and then some poor pain doctor is being arrested for distributing opioids, even though that's why he exists. So it does cause a problem with people being willing to prescribe it, especially if it's in a patient that they aren't taking care of themselves on a regular basis. In the answer to one of the other questions that was posed a little bit earlier about children with AIP, it's not common for children to have it. They can get it. It's an inborn error in metabolism, so you're born with it. So you obviously can have it at birth and at a very young age. In terms of what would trigger it as a teen or a young child at age 9 or 10, I don't know. But what tends to happen is that when you think about where porphyrins are used in the body, they're used to make blood, they're used to make the cytochrome system in the liver, and they're used to make muscle. And I think if you have a growth spurt, you're going to take porphyrins and use it to make muscles for your growth spurt and less so for heme. And if you have decreased heme production, then that would be a trigger for AIP. Now, I don't know that it actually happens or not. I've never seen that in the literature, but that would be my guess anyways of why you might see it in somebody who is just approaching their teen years when they're starting to grow a whole lot.
Yeah, he seems to be in a growth space right now, which is, like I said, I just thought maybe it was more of a metabolism, sugar dependency issue with burning it all off. Because again, my husband's reaction was from intermittent fasting, which ketosis, lack of, and he would have issues where he would try to just, if you would go to a brunch, let's just say, and he didn't eat breakfast, and he's a guy that works out quite a bit lean muscle. If he wouldn't, he would end up, his stomach would start, he would start feeling weird. And
yeah, well, so that could be, right? I mean, so when you think about probably the most common trigger in the world would be a dietary issue of decreased caloric intake, and so that could be. I again, I don't know. I can't say over a computer what's going on, but those are two possibilities for a person that's young. And
at the medical school at Pitt for 8 years.
One quick question on, so he's seeing the hepatologist tomorrow for the first time. Is there any particular you think we should be asking that would help?
I tried and it doesn't work.
Is there any particular questions we should be asking or helping to steer this provider towards to help, in his prevention?
Well, I think, the first thing you ought to do is be sure that everybody knows your family history, right? I mean, and as I said before, porphyria is a multidisciplinary issue, and most hepatologists would have seen or have in their training have learned about porphyria. And so probably the first thing he's going to do, if you tell him a story, the first thing that's going to pop into his mind is, could this be a case of porphyria that you're describing? So I think that's absolutely the most important thing that you can do. Now, I want to just make a comment about that too, and that is for what it's worth, which isn't worth a whole lot, but I gave some years ago, I gave a lecture here at the University of Pittsburgh to medical grand rounds, and it had in its title porphyria, and 12 doctors came. I gave the same lecture a couple of weeks later to our division of hematology oncology, or I'm sorry, to our division of gastroenterology, and 65 people came. So there's a definite difference in interest there. While there, I was told by the head of gastroenterology that they had given up looking for people with porphyria because they haven't found a case in 30 years. And they just didn't look. The following week, one of the fellows in our gastroenterology program, who's now down in Texas, made a diagnosis of a person with acute intermittent porphyria.
Yeah.
So it's kind of interesting because you would think that in gastroenterology, people would be very much attuned to this because people present with abdominal pain, right? But there are people that present with abdominal pain that is otherwise not due to gallbladder disease or GERD or something like that. It's primarily irritable bowel syndrome, and that's what they think of. So you have to say to them that you have a family history of this. And oh, by the way, it's been proven that we have it. It's not, I think, it is, it's been diagnosed. And my son has a similar issue. They'll know what to do after that.
Thank you very much.
That's great.
Can you hear me?
Yes, is this Bonnie? Who's speaking? Okay.
Oh,
Nicole, would you like to close her up today? Can you hear me?
It looked like Bonnie was trying to.
Yeah,
speak
okay,
again.
all right, sorry.
Are you there, Bonnie?
No.
All right, well,
Can
first of
you
all,
hear me?
oh,
Yeah, yeah,
yes,
Can you hear me now?
yes.
yes.
Yes, I've known Desiree since I was 22 years old. She helped me with porphyria years ago, and I just have talked to her recently. But my question is, all the things that I've gone through here in Pittsburgh, living here, never knowing about Dr. Roy Smith, even going to doctors in this area, I guess I'm asking after all these years, if he is available for consult with me or any other patients that might be interested.
Bonnie, as you know, in Pittsburgh, there is a division between insurance companies as who goes to what medical system. I'm available for anybody with any porphyria, period. It's not my availability, it's the availability of whatever healthcare providers provisions you have with your insurance company. But I am at the University of Pittsburgh. I am the primary guy that sees the porphyria patients, and I'm happy to see you or anybody. Doesn't matter who. I don't care. It doesn't matter to me whatsoever.
I have high mark insurance, but I've had variegate porphyria. I saw Dr. Bloomer years ago, but then some people aren't sure whether I have it or not.
Yeah. So you would have. I think you would probably have to get some sort of special dispensation from Highmark to be seen at the University of Pittsburgh. I don't know that, for sure. There are certain diagnoses that they recognize that their hospital system can't take care of. But that's something you would have to check into. But I'm happy to see you. I'm happy to see anybody. It doesn't matter.
Yeah, I appreciate that. I was seen by Dr. Harry Wexler, who was a dermatologist blood specialist years ago, and did the feces and urine tests, and even tried plasmapheresis years ago, which did not work. But I've been pretty much free of symptoms, and yet later in life, I have been experiencing back pain and spinal pain and just things that pop up out of nowhere. And I have diabetes on top of it, which was hereditary from my family. But I'll talk to my PCP here, who is a young doctor since my former PCP has retired, and I hated to see him go. But thank you for your time, and the lecture was very interesting. I appreciate all of that. And Desiree, to you and Nicole as well.
Hey, Bonnie,
Thank you so much.
Bonnie, as a practical issue, if you're interested, we do a lot of telehealth, and the fact of the matter is, and this gets back to this idea of centers of excellence, is that most porphyria patients, with the exception of making the diagnosis, can be treated locally when you stop and think about it. And if your PCP is willing, I can provide him with the guidance that he may need, just via telemedicine. I'm happy to do that. It's no big deal.
I would appreciate that. I will tell her. She's just a young doctor with a few years of experience.
That's great. All
Well,
right,
thank
Nicole.
you, everybody, and especially Dr. Smith, that you have stayed on this long is just absolutely incredible. Thank you very, very much, and everyone else too that's still on, and for coming on and helping us kick off Porphyria Awareness Week. And Desiree, you answered so many questions as well, and thank you to Mayra and Sharon and Megan for sharing their stories, and thank you everyone for being here. And we hope to see you the rest of the week in our other activities, and hope everyone has a satisfy the soul Sunday, and we'll take it from there. Desiree, is there anything you want to close with?
Bye, everyone.
Bye-bye.
Thank you again, everybody, for all the information. I truly appreciate every single one of in this opportunity to be on this, to learn about this disease that I have just recently been diagnosed. I thank you all for your stories and your kindness and your help.
You're welcome.
Thank you, everybody. Take care.